It often happens that preterm neonates leave the neonatal intensive care unit with long-term respiratory comorbidities. Very early ventilatory decisions play an important role in this scenario. According to the literature, each additional day of mechanical ventilation represents an increased risk of pulmonary dysplasia, infections, mortality and lifelong consequences. Target and timely interventions require real-time monitorization of how the newborn responds to the treatment.
We are talking about the preterm patient's 30 weeks of gestational age and around 2 kilograms of birth weight. This patient was withdrawn from mechanical ventilation to CPAP. The patient remained stable and in-light monitoring showed a homogeneous ventilation distribution. After 24 hours we could note through in-light screen a loss in the left lung ventilation before clinical changes or the decrease of SpO2. So we increased 2 point in PEEP. And after 2 hours we could note on in-light an improvement in ventilation distribution. So the baby remained in the CPAP.
This was an extreme preterm baby, born around 29 weeks of gestation and weighing around 1 kilogram. While the baby was struggling to keep the oxygenation alright, we could see Pendeluft oozing in light, and this was a result of the very strong efforts of the diaphragm of this baby. After less invasive surfactant was given, this baby started breathing more easily. We could see a better lung aeration and lower respiratory efforts in this baby, all we want at the bedside. The window of opportunity we have when dealing with extreme fragile preterm infants is very narrow. We gotta promptly choose what to do at the bedside in the right way to minimize immediate and later on risks for this preterm infant.
In light, for each patient, in real time.